Good morning. My name is Javaid Sheikh, and I'm the Dean for Weill Cornell Medical College in Qatar. It's truly a pleasure and honor to be moderating this very important session. We had a fantastic session this morning on how to leverage technology in the service of learners and how to, in many ways, replace, enhance the outmoded models that we have of learning and teaching. And we are going to be building on that. We will go to the next phase, whereby we'll be talking about how do we leverage technology to the advantage of customers, people who will be using it, whether they are students or whether they are customers, patients who will be using healthcare later on. We have two fantastic speakers here today. Initially, I'll be introducing Dr. Catherine McKnight, who is from the Research Triangle Institute, and she will be talking about the use of technology as how it enables teaching and learning from the teacher's point of view. And then I'll be introducing Cynthia Walker, who represents Medtronic, and she will be addressing how the technology companies, which are making devices and other technological innovations, how they are addressing patients' customers' needs. So before we get to that, one other thing, housekeeping. Each of the speakers will be speaking for about 12 minutes, after which I'll be asking each of the tables, every one of the tables, to huddle, and you'll be given 5 minutes to come up with one question each. So 8 tables, one question each. We'll have about 25 minutes afterwards and 3 minutes per question from each table to be addressed to one of the speakers so we can get involved in a very meaningful discussion. So with that, let me get going here. All right. Okay. All right. So since I'm pinch hitting for Dr. Talib in a rather short time frame, thought it'd be a good idea to warn all of us and to remind us that despite what looks good on paper and theoretically, it does not always succeed in real life. So we are all very familiar with what we have here. This is from one of the reports of National Academy from a couple of years ago, looking at the financing model of health professions education. Now, very reasonably speaking, there are population health needs which should drive the demand and supply and then health professions education. However, unfortunately, as we all know, it does not work in a straight line, and primarily here because the prevention, self-care, which should really be driving the demand, does not do so because it's not reimbursed. We have perverse incentives. So there's an insurance system. So there's a mismatch between what should be driving the demand and how we provide the service. So what we have is now underserved populations and expensive care, which is being delivered versus prevention. Very similarly, the demand, which should be driving the supply, does not always do so because you have underemployment there and also a saturated labor market, and not everyone has good health insurance. And then continuing there in the same vein, health professionals who do get trained don't always, always spread out similarly geographically, but they of course aggregate in the cities as well as they aggregate to specialties which pay well. So again, theoretically, what should have been an easy standardization does not work that way. I thought I use one of the slides, the next one, from our own experience in Qatar. Our medical school is about 15 years old. And when I went over there initially, about 10 years ago, we were about 5 years old at the time. This was the first U.S. medical school which was established outside the U.S. let's bring it back. First medical school, U.S. medical school, which was established outside the U.S. and gave U.S. degree. So these students were going to get Cornell University degree, and they do get Cornell University degree, except the model as we envisioned, as it was envisioned initially before transplantation, it really did not work out. So about 10 years ago when I went there, it was about 5 years old, and we were about to graduate our first class. It's 6th year after high schools. The issues were that we, of course, from Cornell University's side, we wanted to keep the same standards, which meant the local students, because they were not prepared very well, could not qualify. So when I show up over there, there was a lot of arguments back and forth, and really dissatisfaction with us, even though we were about to graduate our first class. And so what we did at that point was we adjusted to the ecosystem, really. It's just a small example in the system of adjusting to it, the demands. So we reached out in high school, created multiple programs, but importantly, the theme was to identify bright students who had interest in healthcare at 9th and 10th grade, bring them in weekends, evenings at times, summer and winter, and then create an optional one-year foundation program, English, Math, Sciences. I mean, remember, English is their second language, and when they are taking the test, which requires speed, if it's not their first language, that also delays the whole thing. And then we created the 6-year integrated program, and then we have residency training approved by Eric and colleagues from ACGMEI International in about 17 specialties. So it is working out now, about 2/3. So when I took over, actually about 9 years ago as dean, for the last 3 years, only one of our incoming students was a Qatari national. Now we have 1/3, 1/3, and 1/3. 1/3 of our students are Qatari national, prepared through this program, another 1/3 from the surrounding region, and another 1/3 from everywhere else in the world. And there are no quota systems, it just tends to fall that way. And then we thought, since we are doing so reasonably well, why not go beyond, maybe push our luck? Okay, 1 minute remaining, right, push our luck. So we thought we'd take leadership position in terms of creating major population health programs addressing the elementary school kids' health and wellness, and that's a program which has started. And we have also created an international organization which is focusing on innovations in global health education. So with that, this is really to use a model to say that, yes, of course, we can adjust and we can adapt. Let me introduce our first speaker, Dr. Catherine McKnight, who is a member of the Research Triangles Institute Center for Evaluation and Study of Education Equity, whose work emphasizes teaching and learning, school improvement, and educator effectiveness. Using the latest quantitative social science methods, Dr. McKnight develops studies of mission-driven organizations and collaborates with policymakers to turn research findings into practice. Most importantly, she is at this time involved with the study of parent-teacher home visits in 4 districts across the United States, looking in particular on implicit biases related to race and culture that may affect the visits, and conducting focus groups of the educators and families involved.